Now, thank you, Jake. Thank you. Jake Record Hannah. I'm giving you a new middle name, Jake.
That's okay.
Thank God you're on, you know. It would occur to me about halfway through, and then I'd have a lot of very unhappy people later on. Anyway, yeah. So, Phil, are you with us yet?
Yes.
Hi, how are you?
I had to get my earphones. Sorry.
That's okay.
You got me?
Yeah, we've got you. Where are you?
Good.
Are you in Mill Valley?
No. Oh, are you talking to me?
Oh no, I'm not talking to you, Ken Mason. I'm talking.
Okay.
I'm looking for Phil Febbo if he's on yet.
Okay.
No, it doesn't sound like he is, so I'm sure we'll get him any second. So let me just give those of you who are on and who are not familiar with Cancer just a quick introduction. We are the second generation of the Reluctant Brotherhood, which still continues, but the Reluctant Brotherhood really is focused on providing men with emotional support. We have more of the technical support groups here, both for prostate cancer and for other diseases. And we will be expanding that over the next 12 months. If you're not familiar with Cancer, you've never joined one of our groups before, I strongly recommend you go to the website and you will find a lot of information. We're running, as far as prostate cancer is concerned, which is really what most of you on the call are most interested in, we're running a group for early and low and intermediate disease, which meets a couple of times a month, and anybody who's on this call is very welcome. There's no sign up. You can drop in any time. The voice you heard before of Ken Mason is one of the moderators. Our other moderator right now is on vacation in Vietnam, Peter Kafka. And then we also run 4 calls a month for advanced, recurrent and high-risk disease. Those are first and third Mondays, second and fourth Tuesdays. The schedule for this month is going to be a little different just because the calendar's weird and we're going to have to shift the Tuesday meetings so we don't have 2 meetings in a row, but that's generally the schedule. Again, you can just drop in and feel free to join us. We normally have on that call anywhere between 10 and 20 people. So that's where that's who we are and what we do. There were a couple of little housekeeping things that I wanted to just go through. We will, Phil Febbo, Dr. Phil Febbo is going to speak first. I'll introduce him as soon as I know hear him on the line. And
hey, Rick, I'm on the line.
You're on the line. Great, thank you. So I'll just finish my housekeeping. I'll introduce Phil, and then we'll
go right ahead.
There. Thank you. And then we had a slight glitch this morning around 10 or 11 o'clock when Tariq Muqbal sent me an email and said he couldn't make the meeting. So I worked with Foundation Medicine. We have a great stand-in who is on the line, David Marshak, who I'll say more about later, who is the manager of patient advocacy at Foundation Medicine and may well be more familiar with some of the issues that you are concerned with. And we're going to change the format a little bit there, and David and I are going to have a discussion. David's got some videos that he will want to show, and we'll have sort of a chat, and we'll try and cover most of the information that I think those of you who are interested in testing at a more advanced stage of this disease are interested in learning about. If you have any questions, please, both for either speaker, because I can't see everybody and because it's going to be too hard just to open the phone lines or the meeting, if you would send me your questions in the chat box if you're online, and if you are not online, send me your questions to RD, that's R as in Richard, D as in Davis, rd@ancan.org, ancan.org. I will be monitoring my email right the way through. And then I will ask Phil or David as appropriate the question. So let's get straight into working with Phil, who I really want to thank for doing this tonight, because I know that we're competing with Halloween, and sometimes as to what's given the day today, I feel like it's been a whole day of trick or treat. But Phil and I go back to when he first came out here. Phil is a very eminent genitourinary medical oncologist who trained at UCSF and then went to work at Duke and had his own lab. He's one of the very few medical oncologists in this country who most of his career is specialized in the gene aspect of our disease, the genetic aspect of our disease. And for a good while, several years, was at UCSF with both a research and a clinical practice. And then about, I don't know, it must be about 2 years ago now, maybe 3 years ago, he went to the dark side, and he's now the chief medical officer at Genomic Health, and many of you are familiar with the OncotypeDX test. They have, well, more than just one test. They offer several tests, but there are tests that they offer at different stages of early and mid-stage prostate cancer. And I am going to hand the I'm going to be moving the slides on. Phil is on the phone line, so I'm going to hand it over to Phil. I'm going to ask everybody to mute, other than Phil, of course, so that we can give him good silence, and we'll kick off. And thanks again, Phil, for joining us tonight.
Sure, Rick. It's a pleasure to join. Can you hear me okay? Is this
Yep.
is the microphone working well?
Yep. Terrific.
Okay, great. So why don't you go to the first slide? And, this talk and, speaking with patients, advocates, as well as physicians has really changed from about even 3 years ago when I did join Genomic Health to a talk about informing about active surveillance to really active surveillance being part of urology practice. And now the talk is really focused on, how to choose patients for active surveillance and why Genomic Health spent so many years developing the genomic prostate score, what I'll refer to as the GPS, and it's really to help men who've been diagnosed with prostate cancer, who have clinically low-risk prostate cancer and can really, consider active surveillance among the other treatments, radiation, surgery, and a growing number of definitive treatments. And that's why we developed GPS. And yes, as Rick said, I'm a medical oncologist, so I don't cut or buzz. But I spent years of my career with men who were just recently diagnosed in multidisciplinary clinics at Duke, at the Dana-Farber in Boston, and then with Peter Carroll at UCSF, really trying to help men make the right decision for themselves given their disease and their life choices. And I joined Genomic Health because of its track record in breast cancer, but they wouldn't have been able to attract me as Chief Medical Officer without having the best prostate cancer test to help men face this decision. So if you go to the next slide, it's just a quick case history. This one was provided by Peter Scardino at Memorial, and it underscores, many of the characteristics that we see in men once they're diagnosed. You can see this is a gentleman in his late 50s. His PSA is above 4, so that would have prompted a biopsy or at least a consultation with urologist in many practices. And he did get a biopsy. 3 out of the 12 cores were positive. And you can see his Gleason score, which predictive weight, was 3+, 3 equals 6. So he had Gleason 6, which put him in a risk category of 1, and altogether he would have NCCN very low risk disease, and this is a typical candidate for active surveillance today. I know most people are on mute, but some of the questions that come up, and if the format was a little different, that I'd be happy to engage in is, what is this patient's risk? I've already stated that, but what are some of the options that this person would be faced with as far as choosing between definitive therapy or engaging in an active surveillance program? And what is there out there to help them with this choice? What additional information may be out there? And I think these are all very relevant questions and common questions that men face. So if you go to the next question, the next slide, it kind of highlights what I think is an important information to get to. And this is a complicated slide. There are references in very fine print in the bottom, and I apologize for that. This is a slide that I generally use with a group of urologists or an academic group. But what I like about it is it shows two paths, and those two paths are men who have what I'll refer to as adverse pathology, and that means that their Gleason grade is 3+4 or above, or they have extraprostatic disease, so T3 stage or higher, so high grade or high stage disease, as opposed to men who have low risk disease by pathology, meaning a Gleason score 3+4 or lower, and cancer that's all within the prostate, so T2B, T2C, and below. And if you look at the urology literature, what you find is these two groups of men face different paths. So the ones with just the favorable pathology, those men, by and large, do not die of prostate cancer. There's some striking data from Jonathan Epstein at Hopkins looking at 10,000 patients, looking at the path reports, and those men who only had Gleason 6 in their prostates, out of the 10,000, only approximately, I think it was 27, had died from prostate cancer. And when they re-reviewed those cases, the ones that they could actually get the pathology from, they often found some high-risk features that were not appreciated at the time that they were reviewed. So there's been some evolution in pathology. And so it's really, if you have good risk pathology, favorable pathology, you are not at mortal risk of your cancer. On the other hand, if you have high-risk disease, those are the men in whom the prostate cancer can spread and move to the bones and become incurable. So those are the men who can seek definitive local therapy. So the next slide is a cartoon of the prostate, and it underscores a major problem. And this major problem is being addressed in many ways, but it has to do with most men are diagnosed and will continue to be diagnosed with 6 to 12 biopsies guided by ultrasound of the prostate. And I've heard these biopsies described from everything from random biopsies to ultrasound-focused biopsies, but by and large, they are a small sampling of the prostate. And while they get generally into the right quadrant, it's really unclear where within the prostate and within that quadrant it samples the tumor or the tissue. And what this cartoon shows is that in the same quadrant, you could take 5 different biopsies and get different results. One result could be absolutely negative. One could have only low-risk disease, and one could have seemingly very high-risk disease with 4+4. And that's all in the same patient with the same disease. And so that is a bit of a challenge. And when we start talking to men who are facing a decision about active surveillance versus definitive therapy, one of the major elements is the pathology, and we know that this kind of sampling error occurs. And now if you go to the next slide, this is a very complicated, lots of data here. I'm not going to quiz anybody later. Look at the bottom line and where there's a red box. And that bottom red box line just says if you look at all these studies that have published, and you ask the question of the men with 3+3 cancer on their biopsies, and only 3+3, so only Gleason 6 on their biopsies, and you ask what percentage are subsequently found to have higher risk disease in their prostatectomy, is 30%. So a full third of patients who are making decisions based on their biopsy really underrepresents the aggressiveness of their disease. And that's a big challenge. And as I said, there's multiple ways that people are addressing this, but I believe the most successful way will be to move forward understanding the biology. So you're not only restricted to understanding that patients' individuals' tumor aggressiveness based on Gleason and putting them into a pretty big bin of Gleason. You take biology and you individualize that risk. You always have to take into account what their Gleason is, what their PSA is. That's the way to come up with the most refined risk assessment. But then you also use biology. So if you go to the next slide, it's basically the one-pager about what the OncotypeDX prostate cancer assay is. It's based on gene expression, and as Rick said, I spent my career trying to use gene expression to understand prostate cancer behavior and doing trials, bringing that into the clinic. As a medical oncologist, I was primarily focused on more advanced disease, and I was working very hard to obtain bone samples to perform microarrays on. But gene expression is a great way to measure the biology of a tumor, to get a phenotype, and that's what Genomic Health has done. And in this case, we focus on the prostate tumor, and we can measure very little amounts of tumor and get the gene expression from that sample. The test is for those men who really are considering active surveillance. If you have high-risk disease, or if you have made up your mind that you want surgery, you don't need our test. You can make that decision. I would say if you have low-risk disease, the test, you should consider all your options. And if you're considering options, that's who the test is for. And the test helps overcome some of that sampling bias and the sampling challenges and reflects the tumor biology and can give you a more individual and refined risk assessment of your tumor. And we report the results as a GPS score and then what we call freedom of adverse pathology. So what is the chance of only having good pathology in your tumor and being a very good candidate for active surveillance? The next slide is more about Genomic Health than the prostate test. It just shows that one of my great enthusiasm for the company that I joined, and the reason I joined is that since 2004, Genomic Health has been learning how to bring tests like this to cancer patients and their providers, starting with the breast test. We were just reviewing things. We feel like right now, half of women who are eligible for our test get our test around the country. We have complete insurance coverage, and the test is very much part of practice. It's in guidelines. It is now globally recognized, and we have over 200 million lives covered internationally, with the UK's NHS covering it within their public system, and very good movement in France and Germany. What we've done is we've taken that playbook, developing the data that supports that test in breast, and then we've used that playbook to develop the test for colon cancer, for DCIS, an early stage breast cancer, and now for prostate cancer. And I think as you look at our data and the development, you can have a great deal of comfort that we're avoiding what the next slide is. And Dan Hayes, who's an early maven of the biomarkers, he talks about biomarkers quite a bit. And I think it was underappreciated that a biomarker can be as harmful as a bad drug. If a biomarker is not developed well and the information is not valid, or the information is not conveyed in a way in which a physician and their patient can incorporate the information into their decision process and make a quality decision, then you can really get into big trouble. And the patient can make the wrong decision based on the biomarker, move away from required therapy, or go toward therapy that is has side effects. And obviously, in prostate cancer, I'm sure this group is all too well aware of the challenges of the treatments for prostate cancer and the way they disrupt lifestyle and choices. So that's my preamble, and the next slide gives kind of 3 bullets that I want to touch upon. And Rick, just so that I can track with you, right now I'm looking at program of development of the OncotypeDX and 2 others. Right,
Sorry, Phil, I muted. Yes, that's exactly where we are. Program overview, and the first bullet is in orange.
Okay, perfect. Thank you, Rick. I just didn't want to get out of sync. So the next slide, again, another complicated slide, but this shows the playbook, right? And so we're not going to go through all of this. I'm going to touch upon some of the key studies that are coming into play here, but I'm not going to go through each of them. But what I will say is that whenever you develop a test like the OncotypeDX, you have to start by asking, identifying cancer who are considering active surveillance, how to measure the biology robustly so that we could add information there. So we worked with Eric Klein at the Cleveland Clinic Foundation in Cleveland Clinic and looked into the database he had of over 2,000 men who had had diagnostic biopsies and prostatectomies where we knew the aggressiveness. We also knew their outcomes, who ended up progressing, who had a local recurrence, distant recurrence. And we identified genes that had a strong, whose expression had a strong association with all the important clinical endpoints. So aggressive pathology, biochemical recurrence, development of metastasis, and prostate cancer-specific mortality. So important things to keep in mind, we worked exclusively in prostate cancer tissue to identify these genes. We used multiple clinical endpoints to ensure that the genes we identified captured not only one, but multiple clinical endpoints that are associated with aggressiveness. And then the final part we did is we worked with this study with 167 samples where we made sure that the genes we chose could be measured robustly in biopsies. So biopsies contain much less tissue than the prostatectomy, obviously, and there can be 1 millimeter of tumor in these biopsies. Well, those of you who are familiar with laboratory science and biology knows that genes will behave, the measurement of genes will behave differently if you have nanograms of RNA versus micrograms of RNA. And so we wanted to make sure that genes not only were associated strongly with each of the important endpoints, but that they also had an element where they performed well and could be measured robustly in small amounts of tissue. And so that final gene list was winnowed down, and then we went into validation. And I'll touch upon 2 validation studies, one with UCSF and one with CPDR. Finally, we'll talk to the utility studies. So once you have validation and clinical validation, you have to ask the question, well, okay, clinical validation, but will the use of this test change the recommendation of urologists to their patients? And will it actually change the way patients are treated? Because in order to have utility, you have to eventually link your test with patient benefit. And if your test doesn't change practice, there's no chance that it can have benefit. So we'll now walk through a few slides to kind of go through that, and it highlights specific points. So the next slide has a picture of pathology in the prostate, and it underscores the nature of prostate cancer, and that is oftentimes prostate cancer is multifocal and heterogeneous. And so one of the ways we address that is for each prostatectomy specimen where we collected samples to identify these genes, we collected 2 samples from the cancer that was in that prostate. And we tried to have these 2 samples as far away from each other in the prostate as possible. We always chose the highest grade cancer. So that cancer that looked the worst had the highest Gleason. Then we chose the most common tumor seen. So oftentimes we see one area that had a very high-grade focus. We take a sample from that. But then we'd see a much more extensive tumor that may have been a lower grade, and we take a sample from that. And in the analysis, we made sure that the genes associated with outcome were associated with outcome in both the highest grade and the predominant tumor. And that was to help overcome challenges of multifocality and heterogeneity. The other slides, the slides below, show some TERP species, but they also highlight the prostate biopsies, and the gray arrows that are probably difficult to see on the screen highlight how small an amount of tissue that we're working in, and just again goes over the fact that we made sure our genes worked well despite the low amount of tissue. And it does provide some analytic performance. So if we find tumor in a biopsy, 1 millimeter and even less, 96% of the time our commercial lab will produce a GPS. Now sometimes we just get paraffin blocks where the tumor's already been exhausted. Sometimes we see tissue but the tumor's gone. But when there's tumor there, we can find a score. And if we collect RNA, if we can get greater than 10 nanograms, we're almost always 99.5% of the time successful. Rick, the next slide is the process of gene selection, and I think there's some animation that there may be, but it's basically, we started with 727 genes, and we used the criteria that I spoke about, the two different areas, the dominant Gleason, the highest Gleason. We found those genes that had a strong association with outcome in both, that winnowed it down to 288, and then we looked at their analytic performance. We looked at the pathways, the biology they reflected. We looked at the strength of associations with outcome, and we came up with the final 17 gene score. And the next slide represents those 17 genes. These are the shorthand versions of the genes. This is using the Hugo classification, which is now kind of accepted nomenclature for genes. And what you can see is they represent 4 pathways. 2 of the pathways, if they're increased in expression, are associated with worse outcome. 2 of the pathways with higher expression are associated with better outcome. So the worst outcome genes are stromal response and proliferation. So the higher we see those genes express, the more adverse pathology we see, the more biochemical recurrence after treatment we see, the more metastases, the more prostate cancer-specific death. For androgen signaling in cellular organization, it's the opposite. So the higher these genes are expressed, the better the patients do. And what's really helpful when you develop a gene expression test, and this is true for our breast, colon, and DCIS test, is that it's very good to have pathways that are balancing each other, because that makes sure if you get less RNA, you can still see some genes high, some genes low, and you take that balance into account. What's also important here are these reference genes. Now, these don't get highlighted very much, and people don't focus on them, but these reference genes are extremely important in that these genes were developed in prostate tissue. These genes have stable expression regardless of tissue content, time of prostatectomy, age of block. These are very consistent expressing genes, and they're prostate specific. And as we look at the performance of our test, I think those genes share an equal role in the success of our test, because they really help make sure we understand whether the stromal response genes are increased expression or the androgen signaling genes are decreased in expression. You have to have that kind of control to be successful. And so that's the signature. So we can move on to the validation of the OncotypeDX genomic prostate score. It's the middle of the two should be gold now. And I'm going to talk to 2 specific studies. We're doing more studies all the time, and and one of the great pleasures I get is that I get to see these studies as they're coming basically off the press, and work with the teams to bring studies to fruition. And we have some very exciting studies that we'll be talking about over the next year to expand the data supporting our test. But the two studies that we have now that support the test, one was from UCSF, and that's really focused on making sure that our biopsy could anticipate adverse pathology, meaning high-stage, high-grade disease in the prostate at the time when the biopsy was performed. The reason why I think that adverse pathology is so important is I already showed you the slide that those are the men who are at risk of succumbing to prostate cancer. But it hasn't spread yet, and there's still time for intervention. And you also want to know, while you're making that decision, do you have disease that's aggressive, that could be at risk, and should you pursue local therapy? And so when we worked with UCSF, we take a rigorous approach as far as setting a statistical plan, doing the analysis on the samples, blinded to the clinical outcome. Once all the sample data is locked down, the laboratory data locked down, the pathology data locked down, we bring all the files together and we open the envelope and we see if we get an association. And we found in this first study we had a very strong association between the result of our test, and that's the genomic prostate score, and the presence of adverse pathology in the patient at the time of diagnosis. The next slide kind of addresses this and shows you how we individualize treatment. So we call this our rainbow slide. And what you see up top is 3 lines, green, yellow, and red. And those stand for the classes. If someone has NCCN very low or intermediate risk disease, those lines represent where they would fall on the spectrum. The dots represent the class. So someone with very low risk prostate cancer has an 84% chance of having only good pathology, having favorable pathology, and a 16% chance of adverse pathology. In low, it's 75%. So 3/4 have favorable pathology, 1/4 doesn't. And in intermediate, it's 56%. So just over half has favorable pathology, and the other half have unfavorable or adverse pathology. What you can see along the x-axis are the GPS numbers. And what you can see is that if you have a GPS of 10 and very low disease on that green line, that puts you up close to 90% chance of favorable pathology. Whereas if you had a GPS of 60, that brings you almost all the way down to 60. And you can see that GPS individualizes the risk for these men across the spectrum of those groups, and by doing so refines their risk of favorable pathology and lets them use that information to make a decision as far as what they do. The next slide shows some implications, and there's a little bit of a build here, but what is shown, we call this our Lego plot, and the distribution that's shown here shows for very low risk, and intermediate, the distribution of men in the UCSF study without any biologic risk assessment. And Rick, if you can just click through, what you'll see is that a number of these men from low shift to very low, are confirmed as low, or shift up to intermediate. A number from the very low shift up to low risk, and a number of the intermediate shift down to low risk. And so you see the individuals who are refined. And for the patients in the low risk, that's where we see the biggest change, where we see a significant proportion go down to very low risk, about 10% go up to intermediate risk, and the individual that I presented earlier, depending on their GPS, could end up with a risk of favorable pathology that is outstanding at 84%, could end up being confirmed as being intermediate, confirmed as being low risk and have a risk of favorable pathology of 75%, but alternatively could be found to have high-risk disease with a or have a GPS of 51 and go all the way up to intermediate risk disease and have a likelihood of favorable pathology of 57. So you can see that that's how our GPS can really help individuals understand where they fall on the spectrum of aggressiveness with respect to adverse pathology. The next slide talks about the CPDR study. Because of the nature of these studies, we always like to have two independent studies confirming the validation of our biomarker with the critical endpoint of adverse pathology in this case. And we did that with the CPDR. And so the CPDR group is a research group that works through the military hospitals, in this case Walter Reed and Madigan Hospital up in Washington. And in this study, we both confirmed adverse pathology. We also, for the first time, validated that GPS could predict men who are going to have biochemical recurrence following surgery based on the GPS. So if you had a high GPS, you had a higher risk of biochemical recurrence versus a low GPS. And I'll show you the curve later. But it also confirmed that GPS was a very strong predictor of adverse pathology. There were a few patients with metastatic disease, and we showed that GPS could possibly predict metastatic disease. There were only 5 patients in that group that had metastatic disease, so we wouldn't call that a validation study. We're doing a much bigger study on that metastatic disease. And then we, interestingly, looked at African American men versus Caucasian men. 20% of the subjects who participated, whose samples were part of the CPDR research, were African American. So we could do a study, and what we found is that GPS had the same strong association with adverse pathology for African American men as we saw in Caucasian men. So that was reassuring because we know the biology can be different between African American men and Caucasian men with prostate cancer. What we're seeing here is the biology measured by GPS and its association with outcome is equally valid in Caucasians and African American men, perhaps not surprisingly, because at Cleveland Clinic, in the samples for which we developed, in whom we've developed GPS, 15% of the men were African American. So we had good representation in that to choose the genes, but it was nice, it was reassuring to see that that information still holds true. So the next slide shows the risk curve for biochemical recurrence. So in this case, the probability of biochemical recurrence at 5 years is along the y-axis. The x-axis is the GPS score. And what you'll see is as GPS goes up toward 100, the risk of biochemical recurrence goes up. And if you just look at the lowest 25% versus the highest 25%, and you say, what is the difference? Well, if you're in the lowest 25%, your risk of biochemical recurrence was only 7.5%. Versus if you're in the highest 25%, it all goes all the way up to 33%. So almost 4 times as likely as having a biochemical recurrence. And you can see the hazard ratio there with a strong p-value in multivariable analysis. So again, another indication that GPS is measuring biology associated with the aggressiveness of disease, and that aggressiveness can be measured by adverse pathology at the time of diagnosis or longer-term outcomes such as biochemical recurrence, metastasis, and prostate cancer specific mortality. So the final study, the next slide just goes over study conclusions, and that GPS with very patients with very low, and low intermediate risk prostate cancer, GPS is prospectively validated as a biopsy-based predictor of adverse pathology that's using its prospective validation on retrospectively collected tissue, that it adds independent. It adds information in addition to Gleason, PSA, and clinical stage, that it assesses the underlying biology, and we talked to that quite a bit, and by incorporating GPS, it allows more accurate identification of patients' aggressiveness and should help those men seek understand their level of biologic aggressiveness and let them seek the right treatment. Now, with the slide deck that I have now, Rick, is there another slide, or is that it?
Let me see. No, I'm back to the first slide.
Okay. So what I don't have here, and I thought I threw them in, and I apologize for that, but we've done the utility studies, and I'll just talk to those, and then we'll open it up for questions because I know it was important to Rick that we leave some time for questions. And as he suggested, I have to move on from my chief medical officer duties to my chief Halloween chaperone duties for my children, my two boys. So the utility studies that we've done, one was a prospective study where we had patients who consent to the study, and they were taken care of by urologists who were familiar with GPS, and we asked the urologist to make a recommendation based on the patient's clinical and pathologic characteristics before they saw the GPS results. They ordered the GPS, and then they got the GPS results, and then we asked if what their recommendation was afterward. In that situation, we saw a 21% reduction in treatment overall, net reduction in treatment recommended, with about a 24% increase in the amount of active surveillance. And importantly, of the men who were initially recommended definitive treatment, 1 out of 4 were recommended to have active surveillance rather than immediate intervention with radiation or surgery. So about 1 out of 4 changed to active surveillance. That's recommendation, and it was important to show that, but when I talk to men and talk to urologists, they really want to see what happened to patients. So we did a follow-up study where we worked with a number of practices, about 7 practices. And we looked and we said, okay, for practices using GPS, what proportion of men are seeking active surveillance? What proportion are getting surgery? What proportion are getting radiation? And then we looked in those same practices immediately prior to the availability of GPS. And again, we found a high proportion of patients were switching from immediate treatment. A larger proportion were seeking active surveillance. Interestingly enough, in that case, it was a higher relative increase. It was about a 50% relative increase in those who were seeking active treatment or active surveillance rather than treatment if you look at what actually was happening. So the information we had from the recommendations actually underestimated the true impact of our test. And so where we stand now as a company is, we feel like we have the 2 independent validation studies, we have utility studies, and that is enough to have this on the market. And I'm working very hard. I spend a lot of time traveling to different insurance companies and medical directors to show them this data and articulate the value so that I can make sure that the test gets covered for patients with prostate cancer. And that's been a big part of my job over the past few months. We're not resting on our laurels. We're continuing the studies for this test, and as I said, we have some very exciting data that hopefully I'll have another opportunity to come back and talk to you about. But why don't I stop there, and I don't know if anybody's had the test or has experience with it, but hopefully this is giving you a good overview of the test, how it was developed, who it's for, and some of the data that supports its use.
Well, thanks, Phil. Just a lot of information, and I know that I, for one, will be wanting to listen to this again. It is recorded, so you'll be able to do that. And I apologize for not quite keeping up with Phil on some of the animation on the slides, but when you listen to it again, you can run your own animation because the slides are all available on the website. If anybody joined late, we mentioned that early on, that the slides are on the website. You can download and watch. I have a couple of questions, and if you have more questions right now, send them to me, email them to me at rd@ancan.org or chalk them up on the chat board. So Dan has a couple of questions. Let me start with the first one, which is he'd like you to compare your test to some of the other products that are on the market. Now, he mentions Polaris and Decipher. If I'm not mistaken, Decipher is a test that is for post-surgery. I don't know if they have an early test, But why don't you talk about why people should be seeking OncotypeDX rather than what else is out there, Phil?
Well, I want to start by saying I think men should seek a test that measures biology to help make this decision. And yes, I work for Genomic Health. Yes, despite that bias, I am convinced we have the best test for men who are considering active surveillance. But I think it's more important that patients get a test rather than no test. You're right, Rick. The GenomeDX has developed and validated their test for high-risk disease and post-prostatectomy. They have a single study on biopsies. It was 57 men. It's really an adequate study to validate in low-risk disease. So it's really hard to interpret how to use their test in low-risk disease. Their strength is for men with aggressive disease who've had surgery who are asking, should they get radiation? Should they get radiation plus hormones? What more should they do to try to help treat their aggressive disease? And I'm a big believer that we're going to see, more and more movement into multimodality therapy for men with locally aggressive disease to try to cure more of those men. And GenomeDX test may help, help move that forward.
Mm-hmm.
In the setting of men who are considering active surveillance, there are now 3 tests that have coverage by Medicare. So the first test was indeed Myriad's Prolaris. Prolaris is a test that measures cell cycle proliferation, or CCP, and that focuses on a single pathway, and that's proliferation, and the more proliferation, the worse you do. And their endpoint is 10-year prostate-specific mortality in an untreated UK population. They developed their test across the broad spectrum of prostate cancer risk, and it actually performs much better in higher risk disease than low risk disease. So I think that their test is quite valid in high risk disease. It's a strong endpoint with mortality, but my challenge with their test is how well it performs in the men who are considering active surveillance. And if you look at their current published studies, the challenge there is that there's no significant association between mortality and their test for men with Gleason 6 disease or below. And so I think that's a bit of a challenge. I think what I like about our test is, one, it was developed, the genes were chosen in prostate cancer, chosen to be associated with all the hard endpoints, all the mortality, METs, biochemical recurrence, and adverse pathology, and then genes were chosen to perform very well in biopsies. And all of our studies that I talked to you about include only samples for men who could consider active surveillance and were only done on biopsies. So I think our development is much more in line with the treatment. And so that's where I feel like we have the better test, and our data is more supportive of using our test in men who are deciding between active surveillance and definitive therapy. Again, I am at Genomic Health in full disclosure as Chief Medical Officer. So you got to take my my opinion there with that in context.
The next question is one about cost, Phil. What does the test run, and how likely is it that you're going to be able to get the test covered by insurance? And what are your thoughts and your suggestions on cost issues?
Well, if you're very low or low, and NCCN very low or low, and you're 65 or over, the Medicare Part B covers it without a copay. So you really should cover it. Or if you have Medicare Advantage, most of those payers now have to cover it if you're 65 and over. We are working to get private coverage for men who are under 65, which is about half the population. And it's still early. What we found from breast cancer is private insurers came on about 1 to 2 years after Medicare started covering, and so Medicare started last year right around this time. So we have about 20 million lives covered for privates, but we have many more to go. What I will say is that our practice is that when we get an order, if a man is going to have a potential out-of-pocket payment of more than $100, we will contact them and discuss that with them. And they have the ability to say, no, I don't want to take that risk. What I'll also say is we have a very healthy genome assistance program, a GAP program, and it's actually quite hard not to qualify for a GAP. So as far as it being covered by your insurance, I would guess that it's probably between 30 and 40% of men right now would have it covered by insurance. For the rest of them, we have a very generous assistance program if they would have an out-of-pocket payment that should cover most.
So roughly what is the, what is the rack rate, if you like? What is the standard rate, and what might a man expect to pay out of pocket if he was eligible for your GAP program?
Yeah, so it's all prorated. So the list price, you can get sticker shock. It's about $4,500 list price. I don't know, it changes a little bit each time.
Mm-hmm.
I'd say, the vast majority of patients who have an out-of-pocket expense, that out-of-pocket is quite significantly lower than that. So it's, in the tens to hundreds of dollars, not the thousands.
Okay. So, so it becomes a really valuable test, because for most men, if they do decide to proceed with some sort of treatment, whether it be surgery or radiation, even if they have good insurance, they're still going to be paying a significant amount as their share of whatever the out-of-pocket is. And this could not only avoid a lot of comorbidities, but also financially save them a lot of outlay for a minimal upfront investment. I'll leave that as
something.
So
it's something we're very careful about.
Right. Right. So one more question, and I'm not sure to what extent it addresses the OncotypeDX test, but one of the gentlemen is asking, does genomics use the pathology report to select the tumor tissue, or look at the block on their own before selecting the tissue to use? Now, I guess it does. It does address what you receive. You're going to receive the wax and the pathology report. How do you decide what you're going to test? You still with us, Phil? Oh, did we lose Phil? And my apologies to Surfcaster, because it sounds like we lost Phil. I heard him say, uh-oh, and then I think he may have gone. Well, we're almost at the end. If he does come back, then we'll put that question to him. I actually misread the question. My apologies to you. I now see what you're getting at, and it is a good question as to how they decide what samples to actually test. I'll try and Surfcaster, if you want to drop me a note on rd@ancan.org, I'll try and get an answer from Phil later on and get back to you on that. And if anybody else has any questions about this OncotypeDX test, I was hoping to ask Phil a little bit about the other tests that they are innovating. I did hear, for those of you, we're going to be moving on to advanced disease, but Phil did tell me that they're working to make a commercial ARV7 test readily available, which for those of you who considered that test know is a big deal, because right now it's an awfully difficult test to logistically to get done. So one last call for Phil. No, maybe he ran into a trick or treat. I don't know. So let's move on, and I think, yes, David, you're with us, correct?
Yes, I am.
Hi, David. So let me say a few words about Foundation Medicine and David Marshak. Foundation Medicine, and David will fill you in a little bit more on the history, is one of the very earliest companies to offer a genomic profile on a tumor, on a tissue sample of a tumor for many different cancers. This is not just for prostate cancer. They offer this analysis for a number of different cancers. And this is a very essential part of what most of you have heard of as personal medicine. Personal medicine, 5 or 6 years ago, when I first heard the concept, I thought, poof, this is going to be not in my lifetime. And here we are 5 or 6 years later, and commercially, we have the option to go out to get a test to see if our individual tumor has something called an actionable gene, and we can then find a medicine that might not be approved for our disease to treat that that gene. Now, I am personally familiar with probably 10 men or more who have actually used Foundation Medicine, and familiar with at least a couple who have had very interesting actionable results. In most cases, Foundation Medicine is going to find an actionable gene. The question is whether there is good medication out there. So what we're going to do now, let me just say a few words about David's background, which I did a quick search, David, and discovered that you've been with Foundation Medicine for about 4 years, and you were with another genomic company before then, and that you have a background in biology from Cornell and an MBA from BU in the health sector. When I did my own MBA, which was many years ago at Chicago, they actually offered a health sector MBA. I don't know if they still do that, but it was one of the few specialty MBAs that was available 40 years ago. So let me first ask you for a quick introduction to Foundation Medicine, and just a little bit about what it is that you do, and let's start there.
Yeah, absolutely. And if I could actually ask Rick if I know we were talking about me taking over the control, but my internet connection's been a little spotty, so I wonder if you could just keep it with you, and if we do kind of look at the website, I can just kind of direct you to the place to click on to.
Absolutely. So just bear with me 1 second, and shall we're going to start on the patient portal. Is that where you wanted to start?
Yeah, if you just go to mycancerisunique.com.
There you go. So I've also brought up, I have your Foundation One site and your Foundation Medicine site readily available. So
okay, great. So thanks for the introduction, and thanks for inviting me on your call today. I know we've got Halloween tonight, but no World Series on at least for tonight, and I'm from Illinois originally, so I'm hoping the Cubs can pull it out in these last couple of games. So I'm going to talk about the Foundation One test and how you could how that could factor into your care and choosing treatment options. I don't have studies to talk about or slides, but I think Rick and I are just going to kind of have a conversation here. May look at a video to show it to you. And I've been with Foundation Medicine for 4 years, and for most of that time, I've been in a client services role. So that means working with oncologists who might order the Foundation One test, pathologists who would send the sample to us for testing, or patients or family members like yourselves who are interested in learning about the test and what kind of information it might provide for treatment. So just as kind of a brief overview of how it works, the Foundation 1 test is what's called a comprehensive genomic test or a comprehensive genomic profile. That means that we perform the same test for all types of solid tumor cancer patients. So whether you have prostate cancer or breast cancer or lung cancer or colorectal cancer, we perform the same comprehensive genomic test. In this test, we take a tumor tissue sample and we extract the DNA from it, and we sequence the DNA for 315 cancer-related genes. Some of those are more commonly associated with certain types of cancer, some are more commonly associated with other types of cancer, but by doing that, we can see any gene that might have an alteration. And the way you might compare that to other types of tests where you might test one gene at a time or a smaller set of genes is you're looking for specific things at those points, whereas we're casting the net as wide as possible. So we might find an alteration or a mutation in a gene which you never would have thought to look for otherwise, and that may be associated with a targeted therapy option. It may not typically be used for that type of cancer, so it may not typically be used for prostate cancer, but it could still be beneficial. And so the way our test works is we identify what genomic alterations are present in the tumor, and then what targeted therapy options either for that type of cancer or for a different type of cancer could be beneficial. And also we identify clinical trials that could be worth looking into. And essentially what a targeted therapy is compared to, say, a chemotherapy is that a targeted therapy acts specifically on these biomarkers, these genomic locations where the shape of the molecule can mean that either this targeted therapy is more likely to be successful in acting on the cancer or may be resistant. So you can really, these therapies, instead of like chemotherapies where they attack a very wide number of cells, including, hair cells, other body cells, these are much more pinpointed at the cancer cells themselves. So with that, maybe we can see if we can just supplement that with a little video.
Sure.
So if you could scroll down a little bit, a few screens down.
I will. But I have to say, let me just say one thing. For those of you who are on the phone line, the URL for this site is www.mycancerisunique.com. My Cancer is Unique. That's without any spaces. mycancerisunique.com. And hopefully you can bring that up. I'll just give you a minute to try and get to it. And at the same time, and I know that there are a number of people who have probably noticed this, who are looking at the screen, we notice, you being the manager for patient advocacy, we notice that while you have, 7 or 8 photographs at the top of the screen, they're all women. And so just wondering whether we could get a prostate cancer person somewhere up there as a...
That's a really good point.
It is.
Absolutely. Yeah, that's interesting. I hadn't thought of that before, but like we were talking about before, our test is used for whether it's breast or ovarian cancer or lung cancer, which affects both men and women, or prostate cancer, colorectal cancer. But that's a good point that we want to show that diversity of patients that we could test there.
And we would be happy, AnCan would be happy to find you good candidate to use as a somebody that might want to appear up there. We've got a number of men, I think, that that might be willing to volunteer. So we can talk about that later.
Okay.
So
Yeah.
we'll
Sounds good.
I'm scrolling down to
Yeah, right there, getting started with
right.
Foundation 1. If we
Right.
could see if that video will play.
Okay, here we go. So gents, if you're following along with me, or ladies, please scroll down to Getting Started with Foundation 1, click on that, and you'll see that another screen comes up which says Foundation 1. There's a little arrow, and I'm just clicking on that, and we should be off and running.
Not sure if the audio is coming through there
Right.
from our end.
Oh, I'm not sure. Let me turn it up. I'm going to stop it for a second because I'm hearing it fine. Is it not coming through to everybody else?
No, we're not hearing it.
You're not hearing it. Well, I can only apologize. And
Yeah, I was thinking this might happen. I think sometimes when you try to play a video over a web conference, it can be a little more complicated. But I think, you know, this is just kind of an overview, but actually I kind of went over these aspects just in speaking to you. So for all of you participating, if you'd like to just get another kind of summary of it, maybe it's a video you can just look at after the fact. But I think in my description so far, I kind of covered how the test works. So maybe I can, if it would be helpful, I can talk a little bit about how the process would work between you and your oncologist, and then we can talk about, you know, cost and any other questions you might have.
absolutely, go ahead.
Okay, great. So so hopefully I've given you a little bit of an idea of why it may be helpful to have this Foundation 1 test, and we can revisit some of those aspects, especially if there are any more specific questions about this test compared to some other tests you might be considering. But let's go to the point where you've decided you would want to have the Foundation 1 test. The way it works at that point is your oncologist would order the test and just fill out a test requisition form and fax it into us. And then we take care of contacting the pathology department that has the tissue sample, have it sent in to us. And once we receive that tissue sample, we extract the DNA from the tumor tissue. And we need at least 20% of the cells in the sample to be tumor cells because we're interested in the tumor DNA. So sometimes if the percentage is not high enough, we would need to look for an alternate sample where we can have a high enough percentage of tumor cells. But if we are able to extract enough DNA of the tumor DNA for the test, at that point we sequence it using next generation sequencing. And we're sequencing it for 315 cancer-related genes. So those are portions of the DNA that would code for a protein. And we're sequencing the entire coding region of each of those genes so that if there is any kind of mutation within any of those genes, we would be able to identify that. So then we're able to see what the alterations are that are present, and then once we've identified those alterations or mutations, then we list the targeted therapy options or clinical trials, like I mentioned a little bit earlier. In terms of the cost,
can I just hold
actually, yeah, sure.
Can I just hold you there before we get onto the cost? So a couple of questions that I think occurred to me and may occur to at least one person who's watching this right now, because he sent me an email with this very question in the last few days, is when is the right time to test? I realize, and we all realize, David, you're not a doc, and so you're not in a position to give medical advice, but very often what we find, and this I speak specifically with respect to prostate cancer now, although we've used the test, I've worked with people who have used the test for other cancers, that men don't know when they're right to test. They may not have metastasis, but they may be using advanced drugs. They've become hormone resistant. They've failed what else is out there. When should they get tested, and how do they know if the Foundation Medicine test is right for them?
That's a really good question, and what we've found up to this point, and our test has been available for about 4 years now, is that most of the patients who have our test performed are late-stage cancer, mostly stage 4, some stage 3. But most of the time when a patient, whatever type of cancer it is, whether it's prostate cancer or another type of cancer, this is the stage in the treatment where you've tried a lot of other treatments. Maybe those aren't working. You've tried various chemotherapy regimens, now looking for something else. And you've kind of exhausted those other options. And certainly for those patients, it's a good option at that time because you can identify these new targeted therapies that your oncologist would not have thought to consider otherwise. And so we're able to help those patients. But we actually are hoping that more patients will have the test sooner, before the cancer has gotten to a stage where you're much sicker and you've had more time with treatments which may or may not work. And if you have the test sooner, relatively soon actually after diagnosis, you may decide at that point there may be a match to a targeted therapy which your oncologist thinks is a great step for you at that stage in your care. Or it may be useful information, but it may be something that you kind of put off to the side and say, you know what, we've got a certain line that we're going to try, but if there's resistance develops there, we know this is there. So our test is all about providing as much information as possible, and so we feel like as long as there's the tumor there and there's a high enough percentage of tumor cells, go ahead and run the test and arm yourself with that information so that you can take the next step with getting a targeted therapy either at that point upon getting the results or at the appropriate point thereafter.
Mm-hmm. So somebody who is stage 3, by definition, is sending you a sample from the primary tumor.
Mm-hmm.
What often happens with prostate cancer is that the primary tumor is treated, the disease comes back, it comes back in about 30% of men, and for a lot of men the primary tumor isn't available, and yet their PSA is rising. They may have been identified with stage 4 disease because there may be some evidence in the lymph system, but there is no tissue that can be biopsied and sent to you. There may well be some prostate tissue left from the pathology report, the post-surgical pathology report, but that could be 2 or 3 years out of date. And one thing we know in prostate cancer is that the disease changes pretty quickly. So what you saw 3 years ago might not be what you see today. So what can these men do? What sort of tests should they be ordering? I mean, can they still come to Foundation Medicine?
Yeah, that's a good question. So first off, we will test either primary tumor tissue or metastatic tumor. Really, at that point, it's whichever site has enough tumor tissue can be one that can be tested. So we do both primary and metastatic sites. But we have found that concern from patients, especially with certain types of cancer like prostate cancer, where sometimes it can be hard to get enough tissue to run the test. So, and we were finding sometimes if we weren't able to provide results, that can be a tough thing to say, you know, I'm having this test, but now if I'm not able to get results, what's next? We do have another genomic sequencing test that's called Foundation ACT, and what that test is it, instead of testing the tumor itself, the tumor tissue, it tests circulating tumor cells or circulating tumor DNA, which is circulating in the bloodstream. So we can actually take 2 tubes of blood and have that sent in to us and sequence that. It's not quite as comprehensive as the Foundation 1 test. So instead of testing 315 genes, I think we're testing 60-something genes in the Foundation ACT test. But these are some of the genes which are associated with targeted therapies, and so that can be a great option if there's not enough tumor tissue to test. You could have this blood test, the Foundation ACT test, and still get some actionable results.
So, that's a really good point. And for those of you who are interested in learning more about Foundation ACT, there is a website, and I think, David, what's the URL for the Foundation ACT? Do you?
I know that foundation1.com, you can get to Foundation ACT from there. So
Right.
I'm not familiar if there's a separate unique URL, but if you go to Foundation1, foundationone.com,
Right.
that's kind of our main test website, and that describes we essentially have 3 different tests. One of them is Foundation 1, which is our comprehensive test for solid tumor patients. Then we have our Foundation ACT test, which is our blood-based test for solid tumor patients. And then we have a 3rd test called Foundation 1 Heme, which is for hematologic patients,
Right.
such as leukemia or lymphoma patients.
Right. So if you go to the, for those of you listening, afterwards, you can go to the Foundation 1 site, you can pull up Foundation ACT, and there's another short and very good little video on how Foundation ACT test works. It's easy to understand and I think very helpful. It does not test, as David said, it doesn't test circulating tumor cells, but it tests tiny little bits of, they're called SNPs, little bits of the tumor that have DNA that's sort of broken off and is floating around in the blood, and the test is able to extract these and then to run an analysis right on those right on the on these little SNPs that they're finding. So the second issue that I want to raise with you, David, which is a real problem, is that there are many men on this call who are being treated by medical oncologists who are not necessarily at centers of excellence, and they may not have a genitourinary specialty. And their eyes may glaze over when we start talking about genomic sequencing because it's all so new. How can we, what can Foundation Medicine do to try and help patients who need to educate their doctors? Because this can happen.
Mm-hmm. Yeah, absolutely. I think even where we are right now, this type of testing is still relatively new, especially at community hospitals. Physicians there may not have as much experience with next generation sequencing. So I think the first thing I would suggest is learning as much about the testing as you can. So we have these websites available, mycancersunique.com, our patient-centered website, and then foundation1.com. And both of those go through various aspects of the test. They have these videos which you can look at so you can familiarize yourself. And I would say really these sites can be good starting places for your oncologist. If you talk with them, they should be familiar with this approach, comprehensive genomic sequencing. And I think if you start the conversation saying, you know, you're interested in really casting the net as wide as possible to see what targeted therapy options are out there, and that's something that you indicate that you're interested in. I think we found that once patients start that conversation with their oncologist, they're sometimes surprised that even if it's not something that's come up in conversation previously, once that comes up, they can look into it further. And we have, especially on the foundation1.com website, we have some information that is meant directly for physicians, because I think a lot of oncologists, before they're going to order a test, they want to have data. They want to have a good idea that this test is likely to be successful. So we have on the foundation1.com a list of publications. If you hover over the Learn More button in the top menu, the bottom button there is publications, and we have a lot of publications out there that show clinical utility and how the information that we find has been shown to have clinical benefit for patients who are able to get on targeted therapies identified by testing.
So I'm on the Foundation One website now, as you can see. Am I on the right page?
So yep, if you go down to the bottom of that drop down, it says publications.
Yep. Whoops. Yep.
And then click on that.
Right. Okay.
And then there's different publications. Like if you click on that says 110 next to it, those
yep.
are our publications for Foundation One. So that can be something that if the physician wants to see a little more in terms of data and evidence of this test being useful, that can be helpful for them to review.
Great. So I think that, and we can help you and will help you through Answer Cancer, but largely some of you may find that what you've got to do with your doc is much what we do on these calls, which is educate you so you can then turn around and educate your doctor. You know, I will say that we know of some situations, those of you who call in regularly are familiar with our friend in Hawaii, in Maui, whose doctor was not particularly helpful, but then when it came to asking for a Foundation One test, he was pretty responsive, and he went out and obtained the test, albeit with some old tissue samples. So then we had to go back and get him to do it again with a liquid biopsy.
One thing,
yes.
Rick, actually, it may be helpful if we look at a sample report just to give an idea
Absolutely.
of what kind of information you'd be getting. So if you go back to the My Cancer's Unique website.
I'm there.
And then if you scroll down below Getting Started with Foundation One, down to inside the Foundation One report, and then on the right side there's Preview Sample Report.
Okay, I've got it, and I'm going to click on that. Yeah, you took the words out of my mouth. I was just going to ask you to that we could do this, and so you can take us through what people will see if they get a report, if they get a test.
Yep. So when you pull up the report, you see the first, so this is a report for lung cancer. So you can see tumor type in the upper right corner says lung, but for you it would say prostate there. We identify the genomic alterations, the therapies associated, and then the clinical trials. So you can see on the sample report that there were 3 genes which were identified as having alterations. So it says both the name of the gene and the specific alteration, whether it was an amplification or a certain portion that may have been deleted or substituted, or any kind of mutation that can happen within the DNA. And then
so let me just stop you. Let me just stop you there for a moment, because for those of you who have to take a breath, for those of you who are long-time Reluctant Brotherhood Answer Cancer attendants, participants, you see their CDK12 as being the second one. CDK12 was what was discovered on Dominic Arestiso's report, and if I'm not mistaken, is in the BRCA pathway, and so that was why he started taking olaparib, which didn't necessarily help. It may have helped a little bit. It didn't help a lot, but I'm sorry. It becomes very personal when you see these genes identified, and you know people that have actually had those very same genes identified on their own reports. But go ahead, David.
Yeah, thanks for sharing that.
Dominic was the co-moderated these calls with me. So.
Okay.
Please go ahead.
Sure. We list the genes which have the alterations, then we list the therapies associated. And there are 2 categories of therapies. One is FDA-approved therapies in the patient's tumor type, and the other is FDA-approved therapies in another tumor type. Those are sometimes referred to as off-label. And that's one of the benefits to having a comprehensive test, is that you can find these therapies, which, again, these might take some more discussion with your oncologist if that's the treatment that's suggested or that's identified as an option. But it's what we're trying to do is provide options, and so you can consider in the course of your care what may be best at that point. And then the third category is clinical trials, and so those are targeted therapies that are still in the clinical trial stage, but there can be options to get enrolled in those. In clinical trials, I think it can be great options to potentially have access to an investigational therapy. We do have, sometimes I know it can be hard to follow through and getting enrolled in clinical trials. We actually have a service at Foundation Medicine that we call Foundation Access Trial Navigator, where we have a partner we work with who helps with all different steps of identifying the clinical trials and getting enrolled. We also have another service we offer called the Foundation Access Care Line, and that's a partner who helps with getting coverage for off-label therapies. And sometimes, as I'm sure some of you are aware, that can be a little bit of a challenge with insurance companies to get those. So if you're interested in following up on either of those services, we can connect you through our client services group, and our client services number, it's actually right there on the bottom of this page, and it's posted all over the website as well, the 888-988-3639. If you have any follow-up questions, we can definitely help point you more in that direction.
So I have a question here from one of our regulars who wants to know, does the test-identified treatments that will not work. In other words, if you have a certain gene that's prevalent, it might indicate that you are not a candidate for a certain treatment. He raises the ARV7 test, the androgen receptor variant 7, which means you would not be suitable for a couple of drugs that are out there. So do you also show that on your report?
Yeah, I think in some scenarios, if a gene is specifically associated with resistance to a drug, that we would identify that. We also, in this report, not only do we identify the genes which have alterations, but we call out some specific genes that you would typically be interested in for that type of cancer, which do not have alterations. But that's not an exhaustive list, so we provide actually our full list of genes. If you scroll all the way down to page 11, that lists the full set of 315 genes which we sequence. So you can know that if we don't identify that there is an alteration, that means that we sequenced it and determined it was negative or did not have any alteration. So that can be useful information as well.
Mm-hmm. So this is a 20-page report, which obviously we don't have time to go through. Is there anything else in the report that that should be highlighted for the fellows that are on the call?
I think for you as patients, the most significant pages are the front page and that page that lists the genes. The other pages are mostly giving references for the publications associated with showing why certain treatment options are identified for certain alterations. And then we also go into a little more depth of the different clinical trials that are offered. But I think certainly if you're active in your care, and it sounds like by getting on this call, you all are active participants in kind of next steps in your treatment. I think staying involved throughout the process, and once the Foundation 1 report comes back, going through it with your physician and seeing what the different alterations are, what the different therapy options are, what the clinical trial options are, you'd probably find helpful.
So another question that comes up before we go to cost is maybe one that we may have to get back to Dr. Mughal on. I have somebody asking, if you have metastatic disease, but it isn't clear that it's not being readily identified in the bones, there isn't any tissue, and you are still, and this is very specific to prostate cancer, you are still responding to hormone therapy so that your PSA is very, very low, whether there would be any benefit to doing a blood, a liquid biopsy. That may be above your pay grade.
I think that is a bit too specific, so I think I'm not going to try to take a stab at that. Maybe if you'd be able to follow up later, and that sounds like a good question. So
it is a good question, and I will. What we'll do, I'm just making a little note here, and I'll send that question to Tariq and forward the answer on. So let's get back to the elephant in the room, which is the cost. David, can you speak a little bit to the cost of these tests and how people can get them covered, and what Foundation Medicine is doing? I mean, we've heard some pretty incredible things. I know one of our guys who I think had to go off with his granddaughter trick-or-treating heard not so long ago that Foundation Medicine was doing its best to backcharge the pharmaceuticals rather than the patients. But why don't you enlighten us a little bit on the financial side of this test?
Yeah, and I definitely can go over that. And I think actually I was struck a little bit by some of the similarities by how we follow up on the billing and reimbursement side, and what Phil was talking about earlier with Genomic Health. So So we do work with insurance companies. We ask that the insurance information is provided to us up front, and then we will bill the insurance company. It's different for commercial insurance versus Medicare, and I know some of you may be on Medicare and some may have commercial insurance, so I'll talk about both of those. The list price of our test is $5,800. It's the Foundation 1 test or the Foundation Act test are both at that level. If a patient is paying out of pocket, we have a self-pay price of $4,600. But we will bill the list price to the insurance company, and at that point, the way the follow-up happens is if the insurance company covers the test, then the patient is responsible for any co-pay, co-insurance, or deductible. If the insurance company does not cover the test, then we will follow up with them and exhaust all levels of appeal. But if it's still not covered at that point, it would go to the self-pay price, except we also have a patient assistance program similar to Genomic Health. It's called the Foundation Access Program, and you can learn more about it on that site, mycancersunique.com. It's either by scrolling to the bottom or by clicking that tab that says Access Program. And we have a financial assistance form to fill out, and it's not necessarily, anyone can fill this out, even if you are not as concerned about affordability or out-of-pocket expenses. Essentially what this financial assistance form does is it gives you an idea of your maximum out-of-pocket expense. So even if the insurance company were to not cover it, then it lists what percent assistance you might get. And I think sometimes people are surprised once you put your family size and your household income and list any extenuating circumstances. In many cases, we are able to provide a certain level of assistance to kind of cut into that out-of-pocket expense. So that's the way commercial insurance works. For patients with Medicare, we do bill Medicare for the cost of the testing, but at this time our agreement with Medicare is still pending, and what that means is we will not bill the patient for anything not covered by Medicare. If you're a Medicare patient, you're familiar with advanced beneficiary notices, and until we finalize our agreement with Medicare, we're not able to issue an advanced beneficiary notice. We also will not back bill at that point once we do have an agreement. So it's something, if you're having the test in the near future, you can go along with that information. If it's a little bit down the road, you may want to call into client services just to make sure it's the same situation. But at this time, if you have Medicare, you would not have out-of-pocket expenses.
Okay. So I guess if you're interested in getting this test, if you are on Medicare or even if you're not on Medicare, that there are ways to make it pretty affordable by working with Foundation Medicine right now. And so I don't think that that dollars should be the reason not to do this test. And I'm familiar with at least 3 guys who have finished up having the test completely covered. I think we've covered most everything that I had on my list, and I've asked the questions that I've received, although let me just check my email again. I've got so many screens open here. Okay, so there's one question that I have from a friend of ours in Tucson who is interested in, and again, this may be above your pay grade. It may be something I've got to send to Tariq, but he's interested in knowing how many of the 315 genes have drugs that are available to treat them?
Yeah, that's a really good question, and I won't be able to give a specific number of that, but I can speak more generally about it. Certainly not all of those 315 genes have therapies associated. And what we've found over time, now that we've been doing our test for 4 years or so, is that as time goes on, the pharma companies are developing more and more therapies. So we find, especially if you go back to thinking about the way that report is structured, that we have clinical trials and we have FDA-approved therapies, you can have treatment options that go through that stage. So you may have the test and there's a gene identified which does not have any therapy associated with it at this time. But then a little while later there may be a clinical trial associated, then maybe that clinical trial leads to an approved therapy. So it's something that over time we hope as research continues to progress, there will be more and more therapy options associated. We also do periodically update our gene list, so that we've expanded. I think when I started we tested for 182 genes, and so over time we've expanded that as more and more genes are discovered to be relevant to cancer.
So David, the liquid biopsy, which has a much smaller panel, are those, I'm not quite sure how to phrase this, but there are 60 or so genes on that panel. Are those the more prevalent genes that one would find amongst the 315, or how do they relate? How do the 60 that are on the liquid biopsy panel relate to the 315 which are on the bigger panel?
Yeah, they are a subset of the 315, so they all are also on the Foundation 1 test. But I think the way you described it is actually a good one. They're kind of the 60 or so genes that are most associated with having treatment options, or perhaps are more common. So the reason why we're not able to do all 300 genes from a blood sample is we're not able to get what's called the depth of coverage needed, because in order for us to really determine if an alteration is present, we actually read over each individual portion of the DNA about 500 times. And so we need to be able to get enough reads to really be confident that that alteration is actually present. And we can do that with many more genes on a tissue sample, but it's harder to get that from a blood sample. So we focus on a smaller subset of genes.
Okay. Now I have a question from one of our Australian gentlemen who's interested in knowing about cost and access overseas.
Okay, yeah, that's a great question. So our test is certainly available to international patients. We've had many international patients have our test performed. We have a kit available that we can send to wherever the tumor tissue sample is located and have it sent to us. We take care of the shipping costs associated with that, and the oncologist from overseas can order the test, and we would work to retrieve that sample. In terms of the billing aspect, our Foundation Access Program actually is only for domestic patients. So for international patients, it would be the self-pay price, which is $4,600.
So it's I'm afraid it's the good news and the bad news, Paul. Okay, so I don't see any more questions, and if that's the case, I'm going to let David go out and do a little trick-or-treating. I don't know. Are you? Oh, it's too late where you are. Where are you, David? In Washington? In DC?
Yeah, I'm in Washington, D.C., so East Coast time here.
Okay, it is a little late, but you can go down to the local bar dressed up as a snip of DNA, couldn't you?
Yeah, that would be a good costume. I should try that.
There you
Actually, they go trick-or-treating year-round in Washington, D.C.
go.
Yeah, I think you may be right.
Yeah,
Thanks,
and
Ken.
they all wear the same costume, suits and ties.
Yep, exactly.
Listen, David, thank you so much for stepping in at short notice to cover for Tariq. You did an outstanding job, and I have a sneaking suspicion that there may be a number of men on this call who will follow up with their medical team to try and obtain a foundation test probably earlier than they might have otherwise done, and hopefully they'll find some actionable genes in that test. You and I will be talking some more, if nothing else, other than to try and get a male picture onto the website.
Yeah.
And I have some other things I want to talk to you about. And gents, I just have one last thing to say, whoever's still on the line. If you found this useful and helpful, then there are two things I ask you to do. One is, if you haven't already done so, and you do use Amazon for your purchases, then please nominate us on Amazon Smile. We are a 501c3. We are listed there, and it means anytime you make a purchase, we will get about 1/2 cent or 0.5%, if you like, for sent back to us, and it will help. It does help. And alternatively, and we're getting to that time of year now, please keep us in mind when you make your end of year charitable giving plans. And with that, much thanks to Phil, who is probably somewhere dressed up as a, I don't know, maybe also a piece of DNA, or maybe with him a piece of RNA, I don't know. And to David, and I hope this plenary session has been useful to a lot of people. So we'll say good night.
Thank you.
Good night. Thank you. Bye-bye.
Good night, everyone. Hey.